Welcome back to another explainer. Today, we're doing something a little different. We're treating the subjective cardiovascular assessment not just as a standard medical routine, but as a high-stakes detective investigation. And our prime suspect? The human heart. It's a pretty fascinating process, really, gathering clues, listening to the patient's story, and piecing all the evidence together to figure out exactly what's going on beneath the surface. Here is our detective's checklist for today. We're going to run through the initial medical assessment, dive into our prime suspect, chest pain, and then explore breath, cough, and fatigue. After that, we'll look for clues in the periphery, and finally, we'll dig into the patient's backstory, including their history and lifestyle. All right, let's kick things off with Section 1, the medical detective's assessment, decoding the subjective data. Now, here's the tricky part. The heart literally cannot speak for itself, right? So differentiation is absolutely key. When a patient reports chest pain, we have to actively narrow down where it's coming from. Is it a true cardiac issue, or is it stemming from the lungs, the musculoskeletal system, or maybe even the GI tract? This is exactly where asking the right questions becomes critical to cracking the case. Let's move right into Section 2, the prime suspect, chest pain. When we're assessing chest pain, we always start with broad, open-ended questions, simply asking something like, how would you describe the pain? You know, as a medical detective, you never want to lead the witness. We want the patient to give us their own adjectives, words like crushing, stabbing, burning, or maybe an aching heaviness, long before we ever suggest them. And sometimes the biggest clues are completely nonverbal. A patient might just use their body to tell you what's wrong. Have you ever seen someone hold a tightly clenched fist over their chest? That squeezing motion is highly characteristic of angina. It's a massive, visible red flag that the heart is seriously struggling. Let's strip away the medical jargon for a second. What actually is angina? At its core, it's just a classic supply and demand failure inside the heart muscle itself. The heart is working overtime, demanding oxygen and nutrients, but its own blood supply simply can't keep up with that metabolic demand. And the result of that mismatch? That awful, squeezing, painful distress signal. To really crack this case, we have to separate true cardiac clues from non-cardiac ones. It's all about contrast. For example, if the pain gets worse when you take a deep breath, what we call pleuritic pain, or if it changes when you shift positions or press on the chest, it's actually much less likely to be cardiac. But if the pain is brought on by physical activity or exertion and then gets better with rest or by taking nitroglycerin, that is a major cardiac red flag. Okay, moving on to Section 3, breath, cough, and fatigue, the silent accomplices. Ever wonder why a healthcare provider might suddenly ask you exactly how many pillows you sleep with at night? Well, they're looking for orthopnea. This is the need to assume a more upright position, maybe even sleeping in a recliner, just to be able to breathe comfortably. By asking about pillows, they are quite literally quantifying your orthopnea to gauge how well your heart is functioning. It's pretty fascinating and honestly quite terrifying for the patient how just lying flat alters the body's dynamics. When you lie down, the volume of blood in your chest actually increases. A weakened heart just can't handle that extra load. This leads to something called paroxysmal nocturnal dyspnea, or PND, where the patient wakes up after a couple hours of sleep, desperately needing fresh air. We also have to be detectives about a seemingly simple cough. Most people just assume a cough means a cold, right? But check out the details. We always ask about sputum, because if someone has hemoptysis, which is blood-tinged sputum, that can actually point straight back to the heart, specifically a condition known as mitral stenosis. Listen up, because this next fact is absolutely crucial. Profound, unusual fatigue, like suddenly not being able to keep up with your family or coworkers, is a top early warning symptom of a heart attack, specifically for women. It's the kind of clue that is way too easily dismissed as just being tired, but to a medical detective, it's a blaring siren. All right, Section 4, clues in the periphery, edema and color changes. If we notice a patient has cyanosis, which is a bluish tint, or pallor, kind of an ashen grayness in the face, we know right away this isn't just a skin issue. It's a direct visual result of a low cardiac output state. The heart just isn't pumping effectively, and it is literally starving the body's peripheral tissues of perfusion and oxygen. And what about swelling or edema in the legs? How do we know if it's the heart or just a local vein issue? Well, the evidence is in the details. Cardiac edema is usually bilateral, meaning both legs are equally swollen. It's dependent and notoriously worse in the evening after you've been up all day, getting better by morning. But if the swelling is unilateral, just in one leg, That points our investigation toward a local vein problem instead. Here's a really sneaky clue. Nocturia. This is waking up at night with an urgent need to urinate. Why on earth does this happen with heart failure? Well, during the day, fluid pools in the legs. But at night, when you lie flat, that fluid gets absorbed back into the bloodstream. Your kidneys then process that extra fluid, forcing you to wake up and excrete it. It makes perfect sense when you think about it. Finally, Section 5, Backstory, History, and Lifestyle. To truly understand the context of someone's heart health, we run through a rapid-fire checklist of their daily habits. We look at their nutrition, like diet and salt intake. We quantify smoking by packs per day and years smoked. We assess alcohol intake, their exact exercise routine, and literally every drug they put into their body, from prescribed beta blockers all the way to street drugs. Interestingly, the rules of our investigation have actually changed over time. For years, people thought a daily low-dose aspirin was this universal shield, but current guidelines now recommend against starting low-dose aspirin for general primary prevention of cardiovascular disease. The only exception is for a very select group of high-risk individuals aged 40 to 59, where the risk of a heart attack actually outweighs the risk of gastrointestinal bleeding. When we're tailoring our investigation for the aging adult, we like to bridge clinical data with real-world living. We do this by asking one remarkably simple question. Does your home have any stairs? We need to know if they climb them, and if doing so interferes with their daily life. It tells us if their own physical environment is actively straining their cardiovascular system. To wrap up this explainer, I want to challenge you to turn the magnifying glass on yourself. Think about your own family history of hypertension, coronary artery disease, or sudden cardiac death. Take a hard look at your daily habits. Based on all the clues we've decoded today, ask yourself a provocative question. How well do you truly know the health of your own heart? Keep learning, keep investigating, and we'll catch you in the next explainer.